All right. Getting it going there, Martin?
Sorry, I need to adjust system preferences, apparently.
All right. Well, Martin is doing that. I'll go ahead and do an introduction. Dr. Escandon, class of 2019 from our residency, did his OB fellowship at Natividad in Salinas. Currently a staff physician at Contra Costa Health Services, where he's part of the faculty, does outpatient, inpatient obstetrics, and general family medicine as well. A lot of professional passions with Dr. Escandon, including health equity, obstetrics, reproductive health, and farm worker health. I still remember Dr. Escandon's R3 or his third year talk on farm worker health. It was one of the more exceptional ones I've seen in my years as a part of faculty. I think it's fair to say that Dr. Escandon is a true advocate for justice in medicine and has been a strong voice for as long as I've known him about the importance of equity in medicine, and not just in the practice of medicine, but also in about who practices medicine. So Dr. Escandon will be talking today about what interventions are effective to reduce the impact of structural racism on pregnancy outcomes. So Martin, please take it away.
Thank you so much for the introduction there, Dr. Jimenez. Is everyone able to see the screen? Great, okay. Good morning, nice to see so many familiar names and faces. Thanks so much for being here, taking time out of your Saturday, and for listening to this talk. It's called Interventions to Reduce the Effects of Structural Racism on Pregnancy Outcomes. I think we should begin with a trigger warning and a content warning. This presentation is going to discuss pregnancy, adverse birth outcomes, race, and racism. We all carry our own lived experiences with us differently, and it's possible that the content of this presentation will be activating, upsetting, and triggering, especially if you've shared in these experiences either as a patient or as a provider. So in response, I encourage everyone to take whatever steps necessary for your emotional health and well-being during and after the presentation. I'd also like to recognize the privilege I have in life and in this space. Among other identities, I'm a cisgendered man, and I'm not a birthing person. Tackling the maternal mortality and morbidity crisis among birthing people of color in the United States really requires strategies that are grounded in Black and Indigenous women's lived experiences, wisdom, and leadership. Any investigation of this crisis really has to begin by acknowledging the violence, trauma, and experimentation inflicted historically on Black bodies and communities. These are experiences that I have not had and I cannot have. My motivations in delivering this talk are to be an accomplice in the struggle for equity, and I approach this work with humility. I appreciate your grace and your understanding. I'll attempt to use inclusive and neutral language whenever possible. After participating in the session, I would hope that you're able to describe inequity in U.S. pregnancy outcomes by race, analyze the structural contributions to this racial inequity, and compare interventions to reduce this racial inequity. We'll start by looking at descriptive statistics. These are data for maternal mortality that uses the WHO definition, which is deaths per 100,000 live births. The death of a person while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. So this is different from what Dr. Lund was talking about earlier, pregnancy-associated deaths, which includes deaths from homicide, suicide, and overdose. So this is an underrepresentation of the true pregnancy-related death rate. The rates you have in this figure are from other high-income nations and the United States. So this is for 2020 for the US. There's a few different years for different European nations. The light green bars at the right are the United States maternal mortality rate. The darker one is 23.8, which is the overall United States rate in 2020. 23.8 per 100,000 live births. In Canada, for example, it was 8.4. In the Netherlands, it was 1.2. And you have the US mortality rate stratified by race on the right there too. The maternal mortality for Black birthing people in the US in 2023 was 55.3 per 100,000. So it's over double the rate for white birthing people in the US. Here are more descriptive statistics that shows a 4-year trend in US maternal mortality, the same definition from the last slide, broken out by race. So you can see the totals, 23.8 in 2020, increased to 32.9 in 2021. You have the same 55.3 per 100,000 live births we saw for Black birthing people in 2020 that increased to 69.9 in 2021. In real numbers, in 2021, there were 1,205 total maternal deaths in the United States, which is up from 861 in 2020 and 754 in 2019. So how can we be sure this disparity isn't due to some difference between these populations? Certainly there are differences in comorbidities that can cause adverse pregnancy outcomes between different subgroups. These are graphs from a JAMA paper in 2021 looking at trends in severe maternal morbidity between 2008 and 2021. Severe maternal morbidity is defined as unexpected outcomes of labor and delivery that result in significant short or long-term consequences to health. There's 21 specific conditions that look through ICD-10 codes. Generally, they're in 4 broad groups like cardiac conditions. You have heart failure, acute coronary syndrome, shock. There's respiratory ARDS, ventilation, temporary tracheostomy, hemorrhage, and blood transfusion accounts for the majority of severe maternal morbidity. This study examined all payer administrative insurance claims database that was representative of about 25% of all admissions in the US during this time period. And what they did is they used statistical models to adjust for comorbidities. Obesity, gestational diabetes, and tobacco use were the most common comorbidities. And they also adjusted for patient demographics, site of delivery, which allowed them to look at the specific effects of, here you see age, type of delivery, cesarean section versus vaginal delivery, and race, and how those affected severe maternal morbidity. This is helpful because most descriptive studies don't look at morbidity with this level of granularity. So you can see a couple things that you would expect. In the bottom left there, you see higher ages are associated with more morbidity. The bottom right, there's more morbidity with cesarean births than vaginal births. In the top right, you see severe morbidity stratified by race. The numbers are listed as diagnoses of severe maternal morbidity per 10,000 discharges. And in this data set, the rates were highest among Pacific Islander people, birthing people, followed by American Indian, then Asian, then Black, then Hispanic, and then white birthing people had the lowest rate of severe morbidity. The majority of the literature that we're going to look at today focuses on Black and American Indian Alaska Native birthing people because the disparities are most pronounced and consistent for these groups. Certainly, this is an area that needs more investigation because these racial and ethnic groups are not homogeneous. Subgroups within these definitions have different lived experiences and result in different birth outcomes. This is back to descriptive statistics, but we're looking at neonatal and infant outcomes. This is the infant mortality rate, which is defined here as death before the first birthday after a live birth. In the US, we have 2019 and 2020. It was almost 20,000 deaths a year. And you see here that Black infants died over twice the rate of white infants. Pacific Islander, American Indian, Alaska Native infants also die at higher rates compared to white infants. And this disparity is consistent across various newborn outcomes, low birth weight, preterm birth, neonatal mortality, along with infant mortality, NICU admission. These are all drivers of the difference in infant mortality that you see here. So we see that maternal and neonatal outcomes are worse for Black and Indigenous birthing people in the United States. But how did we get here? How is this our reality? I think the first important thing to say is that race is a social construct. Differences in health outcomes by race are not based on biological characteristics inherent to individuals. There's no set of genes that delineates whiteness or Blackness. And there's nothing inherently unhealthy about being Black or Native, just as there's nothing inherently healthy about being white. but it is unhealthy to be subject to racially discriminatory structures and systems. So what is structural racism and discrimination? We're talking about macro level conditions like residential segregation and institutional policies that limit opportunities, resources, power, and well-being of individuals and populations based on race, ethnicity, and other statuses. This graphic here is supposed to illustrate how discrimination based on race affects all levels of society. You see it at the core of the earth in this cutout. And it kind of permeates through most foundational social and political structures, rising up to institutions and systems that individuals and communities interact with. Minoritized groups are consistently excluded from power and placed lower on the hierarchy of access to opportunity and health. This exists in the legal system, the housing system, economic systems, the education system, and in the healthcare system. And of course, people and communities interact with these systems every day. So race is not biological in origin, but the experience of living in these structures and interacting with these systems has real biological effects. Marginalized people live in disinvested neighborhoods with more pollution and fewer services at higher rates than non-marginalized people. We get care at lower performing hospitals and experience individual level racism. All of this contributes towards chronic stress that weathers our bodies, and this concentrates into differences in the health outcomes that we just examined. How is it that where we live influences birth outcomes? This is a study from 2023 in The Lancet that investigated differential exposure to determinants of maternal health. What they did was they developed a measure called the Maternal Vulnerability Index. It's a county-level measure of predictors of poor maternal health. So they included measures of the quality of reproductive health care, the physical health of the population, mental health and substance use, the overall quality of healthcare in general, socioeconomic determinants, and the physical environment. They divided counties into 4 quartiles of vulnerability. So quartile 4 has the highest vulnerability, the darker areas on the map there. They used this vulnerability index as a proxy for the local level structural determinants of health and hypothesized that birth outcomes would be worse in higher vulnerability areas. Black birthing people were significantly more likely to live in higher vulnerability areas. So they use this index to look at all birth and death records from the CDC in the United States from 2014 to 2018. And they had their primary outcomes were maternal mortality, you see at the top of the screen there, preterm birth and low birth weight. All of these measures increased as the vulnerability score increased. And you can see that because the slope of these curves on the graph is positive. They also saw that Black birthing individuals had higher levels of mortality, more low birth weight, and more preterm birth at all quartiles. What does this mean? When you compare Black and white birthing people living in equally vulnerable areas, the Black-white disparity persists. You're looking at the white line, the orange line representing white outcomes, and the blue line representing Black outcomes, and there's a difference there. So even when you account for social and structural effects at the county level, Black birthing people are still at higher risk for these birth outcomes. The authors interpreted this to indicate that these local level determinants are part of the pathway to inequity, but they don't explain all of it. So there's the experience of racism that we can't measure in these data and the cumulative biological effects of social discrimination that are going to be the other key parts to this pathway and towards inequity. What about the care we're providing during labor? Is that part of the pathway? This paper is from AJOG in 2016, and they set out to determine whether hospitals with high proportions of Black deliveries have higher levels of severe maternal morbidity than hospitals with low proportions of Black deliveries. They also wanted to see if these differences existed, do they contribute to the Black-white disparity in severe maternal morbidity? They had a nationwide representative group of about 1,140 hospitals that represented 942,000 births. So this was about 20% of the births in the US between 2010 and 2011. They stratified the hospitals into 3 groups. They had the 5% of hospitals with the highest number of Black births, which they called high Black serving hospitals. This was 279 hospitals. Then they took the next 20% of hospitals with the next highest number of Black births that they named medium Black serving hospitals. And the remaining 75% of hospitals were labeled low Black serving hospitals. Black serving hospitals were more likely to be large, urban, have higher obstetric volumes, be in the South, and more likely to be teaching hospitals. In their sample, high and medium Black serving hospitals, 25% of the hospitals in the sample, cared for 75% of Black birthing people. So there is a concentration of Black birthing people in a small proportion of hospitals. These hospitals had higher levels of severe maternal morbidity, the Black and medium serving, high and medium Black serving hospitals. So the difference in morbidity persisted after adjustment for patient characteristics, site of care, and hospital characteristics. They adjusted for variables that could affect morbidity like patient age, income, comorbidities, and the type of hospital teaching or not, and the location of the hospital, the region of the country, and whether it's rural or urban. Severe morbidity occurred twice as often in Black deliveries than white deliveries. And higher Black serving hospitals had higher severe maternal morbidity for both Black and white deliveries, even after adjusting for hospital and patient characteristics. So the authors concluded that the quality of care at high and medium Black serving hospitals could be lower than the care at low Black serving hospitals, and this could also represent part of the pathway to unequal obstetric outcomes, but it doesn't also fully account for the disparity. At the end of the day, it's individuals who are experiencing these systems, and there's a robust qualitative literature documenting the birthing experiences of Black people in the United States. Several themes crystallize when you ask people about their experiences. And they include the historical legacy of mistreatment from the medical community. Patients often report feeling disregarded, feeling pressured into interventions without explanation, undergoing interventions without adequate consent or anesthesia. Patients report microaggression, discrimination, unconscious bias, and overt racism in healthcare. People report feeling poorly cared for, and they understand race to be a primary reason why. Is there a different way for us to study health inequity? Because the public health and medical scientific communities are also not immune to structural discrimination. BIPOC researchers are underrepresented in the medical sciences, and the voices of birthing people of color are very rarely central to the narrative that we tell in research studies. There's a group called the Black Mamas Matter Alliance. It's a Black woman-led cross-sectoral organization that centers Black mamas and birthing people to advocate, drive research, build power, and shift culture for Black maternal health, rights, and justice. They developed a research framework that acknowledges Black women are experts that produce knowledge and will improve the health of their communities. Black women's perspectives need to be central to the creation of questions and seeking answers, and as we investigate the pathway towards equity. And they call for research to be grounded in human rights and research justice. This is kind of a bullet-pointed list of best practices that researchers can follow when we're doing research about birth outcome and equity. And it definitely is based on a human rights framework. So recognizing and respecting the rights of Black mamas, understanding the historical, sociocultural, political, and economic context, investing in Black women as researchers, funding and conducting ethical research that benefits Black mamas, honor and commit to community engagement throughout the entire research process, and include health equity and social justice as key themes in research. What can we do to disrupt the systems that lead to these inequities? Doulas. What are doulas? Doulas provide non-clinical, emotional, physical, and informational support for birthing people before, during, and after labor and birth. They provide hands-on comfort measures and share resources and information about labor and birth, and are there for continuous support during labor and childbirth. When we look at the evidence, doula care is one of the best interventions we have to improve birth outcomes. ACOG has a paper called Evidence-Based Labor Management, and doula care is given an A-level recommendation, meaning obstetric providers should offer if available, and that is a recommendation based on high-quality evidence. I'm showing you figures here from a Cochrane review in 2017 for continuous labor support. Important caveat, they include studies that aren't just doulas. They include any continuous labor support from a doula, an RN, a midwife, or a lay companion. And they show that births with doula care, with continuous labor support rather, have a higher rate of spontaneous vaginal birth, shorter labor length, a lower rate of C-sections, and lower rates of negative feelings about the birthing experience. There's pretty limited literature investigating race-specific effects of doula care. What I'm showing you here is a table from a retrospective cohort study that used health insurance claims data from California, Florida, and a northeastern US state from 2014 to 2020. They're using a technique here called propensity score matching, which I think of as like an enhanced case control study. What they did was they identified around 300 pairs of birthing people matched on age, race, state, socioeconomic status, and the hospital type where they delivered. One part of the pair had doula care, and the other part of the pair did not have doula care. In their study, people who received doula care had half the odds of C-section than people who did not receive doula care. And when they looked at the odds ratio for C-section as a function of race, they found that Black and white birthing people had the same level of reduction of odds of having a C-section when they had a doula. You can see this because in the top right number there, the PSM odds ratio for race, Black versus white, and cesarean delivery, the confidence interval crosses 1. So it was an equal intervention for both Black and white birthing people in this subset of 300 pairs. The authors interpreted this to mean that Black birthing people get the same health benefits from doula care as white people, and that doula care targeted towards Black birthing people could help close the health equity gap. How is it that doulas work to improve health outcomes? Labor support could enhance labor physiology through increased maternal comfort and empowerment, leading to a decreased stress response and healthier labors. I think it's also likely that doulas provide some direct advocacy and mediate communication between patients and healthcare teams. Patients who have doula might also have increased preparation for labor. There's also a model of community-based doula services where doulas have a function as like a pregnancy navigator, helping linking patients to care and services. What about different methods and models of prenatal care? Group prenatal care, we heard a little bit about today. Generally, group prenatal care begins sometime in the early second trimester. It includes a cohort of 8 to 10 patients at around the same gestational age, includes their support partners, an obstetric care provider, and a co-facilitator. They meet every 2 to 4 weeks for a total of around 10 visits. Patients generally socialize before the group visit. They do some data self-collection and have brief one-on-one meetings with the obstetric care provider. There's a suggested curriculum that includes some structured information like childbirth preparation, nutrition, exercise, stress management, and self-awareness of health. But the focus really isn't on a didactic exchange of information from the care provider. It's peer-to-peer knowledge transfer. Pregnancy complications get managed through additional individual visits or specialist referral while continuing in the group model. The evidence on the overall effects of group prenatal care is mixed. This is a forest plot from a 2016 systematic review and meta-analysis of the available evidence then, including randomized controlled trials and observational studies. And there's a trend towards reduction in preterm birth and low birth weight. You can see the overall measures there, those diamond-shaped figures at the bottom, cross 1, which means in this study, they weren't statistically significant. But none of these studies stratified participants in group prenatal care by race. There's some newer evidence now. This study was published in 2022 in AJOG. It was a randomized controlled trial comparing individual prenatal care to group prenatal care. So there were 2,350 patients that got randomized to individual versus group prenatal care. So on the left, you have IPNC, that's individual prenatal care. On the right, you have group prenatal care. This is looking at preterm birth rate. Engaging in prenatal care at all was associated with low preterm birth rates. You see the downward slope of the curve. When you stratify by race, group prenatal care showed a significant reduction in preterm birth and low birth weight. I'm not showing you that graph, compared to individual prenatal care, with actually a narrowing of the disparity gap. You can see the blue line on the right for group prenatal care that represents Black birthing people crosses the gray line representing white birthing people. So the reduction was also more significant the more prenatal care sessions people attended. How might group prenatal care help close the gap? The model is focused on self-directed learning and empowerment, which might be more effective at encouraging patients to increase healthy behaviors or build skills like self-advocacy in the medical setting. I think it's also likely that peer-to-peer learning creates kind of a social bond that could be protective against racism and discrimination. What about the racial identity of the healthcare team? Racial concordance means when the patient and the provider share the same racial identity. There's literature showing that some other healthcare measures, non-obstetric measures, improve with patient-provider racial concordance, patient satisfaction, uptake of preventive healthcare measures. Study on obstetric outcomes is really limited. This is a single-site retrospective study that reviewed all births at a tertiary care center in 2016 to examine if patient-provider racial concordance affected TOLAC outcomes. Their sample size was 1,366 patients. Concordance didn't change the likelihood of attempting TOLAC, but multivariate analysis to adjust for age, BMI, provider level of training showed that concordant pairs did have a 2.15 higher odds of successfully completing VBAC. Why does this happen? It's unclear, but it's possible that patients have greater trust or easier communication with racially concordant providers. This is certainly an area that needs more investigation in obstetrics. How about standardizing clinical workflows and protocols? Does that help reduce inequity in maternal health outcomes? This is a table from a prospective cohort study published in AJOG in 2020, evaluating a standard protocol for induction of labor. They chose to investigate labor induction as an intervention because there's a wide variation in the standard of care and often involves provider discretion. This study was done at the University of Pennsylvania. They were looking at births from 2013 to 2015. It was actually nested within the 4Mommy trial, the one that investigated balloon versus meso for labor induction. So there was a randomized trial arm of 491 patients who had induction via the protocol, which kind of recommended amniotomy and Pitocin at standard points. And there was also an observational arm of 361 patients who had induction at the provider's discretion. They only included term singleton gestations with an unfavorable cervix, and they stratified race by Black and non-Black. Those are the two categories. All of the birthing people in the standard protocol arm had shorter length of labor. So all comers had faster labors with the protocol. Black people in the standard protocol arm had a significant reduction in the rate of cesarean compared to the observational arm. So in the protocol, 25.7% of Black birthing people ended up having a C-section versus 34% in the observational arm. Among non-Black people, there was no difference in the rate of C-section in the protocol versus observational arm. How does this work? How is this affecting outcomes? I think it's unclear. It could be that following a standard protocol discourages providers from different management for patients with different racial identities. It could diminish the effect of unconscious bias at the provider level. A couple broader scale interventions that have been shown to be effective. What if we increase access to health insurance? This is a 2020 study that took advantage of a natural experiment from the Affordable Care Act. Some states elected to expand Medicaid eligibility as part of the Affordable Care Act. The expansion states had higher maximum income limits, which increased the number of eligible people for Medicaid. So far to date, 40 states and the District of Columbia have expanded Medicaid, 10 states haven't. This study compared maternal mortality ratios between states that expanded and those that didn't, adjusting for other differences between the states. States that expanded Medicaid had 7 fewer maternal deaths per 100,000 live births than non-expansion states. When you stratify the differences by race, the reduction in maternal mortality was actually concentrated among Black people, with a reduction of 16 maternal deaths per 100,000 live births for Black birthing people. How does this work? Increasing access to health insurance probably increases access to care. Maybe people have better baseline health before pregnancy, earlier initiation of prenatal care, or better postpartum care in the year after delivering. The last intervention we'll look at, what about just giving people more resources? This is a study of the Healthy Baby Prenatal Benefit, which is a non-conditional cash benefit of up to $81 per month in the second and third trimester. It's a program for Métis Indigenous people in Manitoba, Canada. Low-income birthing people who received this cash benefit were compared to low-income people who did not receive the benefit. People who received the benefit had lower risk of low birth weight and preterm birth. The authors attributed this to improved nutritional status due to the cash benefit. There was a higher incidence of large for gestational age in people who had the cash benefit. You could also consider an effect on stress levels or general poverty being reduced with this unconditional cash benefit. I apologize that that was so fast. Here are my references. In conclusion, we examined structural discrimination and racism and how it affects every level of our society, from systems down to individuals. This discrimination results in the crisis of unequal birth outcomes that we're experiencing today. There are interventions to fix this. They need to be targeted at every level in the pathway to inequity and need to include interventions that we might not typically consider in the purview of healthcare delivery, but it's essential and urgent that we act. Thank you very much for your time and attention.
Martin, that was just perfect. No, it was not rushed. You really are masterful with your language, and the topic, you just nailed it. So thank you so much for that. Saw a lot of talk in the chat about what's available sort of locally and in California. I'll be curious if anybody who's watching out of state has some things that they'd like to add about that. But we have a good 5 minutes right now, so I'd love to hear what other people are doing at other sites and things that they're doing to try to improve outcomes here. I could say, speaking locally, our hospital where our residents and our faculty deliver at recently got a new CME, and recently had a talk with him about doulas, and he was incredibly receptive. So we're hopefully going to start moving towards being able to offer doula services for all of our patients more often on our labor and delivery. And I'll stop talking now and let people kind of jump in with comments or questions that they have. One thing I am noticing in the chat line is obviously the underfunding that goes into doula services, the lack of compensation or the low compensation. So clearly an issue that is ripe for change. I also know that Aaron Lund shared with some of us recently that in April, we're going to be having there's going to be a local workshop film about the Black birthing experience that I'm excited about. So we could maybe try and add a link to that in some of the follow-up email, some of the follow-up messaging we go from this talk today. And then lastly, right now, Dr. Bacon is bringing up the issue with the lack of group prenatal. We've known for a long time. Thank you, Aaron, for putting that in the link. Or putting that link in the chat. We've known for a long time group patients benefit from group prenatals. I love the language, Martin, you put about peer-to-peer knowledge transfer. It's just so perfectly stated. We know it makes a difference, yet there are just so many barriers to that type of care. We all know probably financial is the top of that list. Yeah, so anyone else have any other thoughts before we move on to our last talk of the morning?
About doula compensation, the Center for American Progress has a really good toolkit and kind of economic argument for why we should pay doulas more and how much they save the healthcare system in total. And there's a lot of legislative advocacy around improving doula reimbursement and making doulas more accessible to our patients.
Great. Excelente, doctor. All right. Let's keep it moving and